No, the webinar is organized by the Red Cross, Red Crescent Research Network on Mental Health and Psychosocial Support, which is a group of researchers and Red Cross, Red Crescent practitioners who have joined in a network to try and support more research on mental health and psychosocial support within the movement. The topic of today's webinar is PFA and research on PFA. And basically, the last decades have witnessed a huge boom in different models and manuals and materials on psychological first aid, and everyone is using it in the field in different ways and shapes and forms. But when you actually go and look into the research and the academic literature, there's not a lot of high quality studies documenting the effect of PFA. And this is what we're going to discuss more today. So we're going to discuss what are actually the challenges of conducting research on PFA. Can it be done? How can it be done? And also, what does it mean if we want to do more evidence-based practice? Then what does this mean for our practice? And I'm very happy to see many people on board, and we have a few presenters. How it's going to work is that we have first Eliza Cheung from Hong Kong Red Cross and the IFSC Reference Center for Psychosocial Support is going to present some of the experiences from Hong Kong Red Cross in conducting research on psychological first aid and how they have tackled these challenges. And then next, Koen van Praet from Belgian Red Cross Flanders has been involved in sort of a systematic review on the evidence of PFA, and he's going to present some of the challenges and involved in conducting PFA research, and also pointing at some possible solutions or ways forward for the research. And then finally, Ferdinand Garoff from the University of Tampere will lead a Q&A session. So we'll have around 20 minutes in the end, hopefully, for questions and answers.
I'm so happy to meet all of you here at this webinar and to share some of our some experience in doing psychological first aid training and services in emergency. So basically, in Hong Kong Red Cross, we have been using psychological first aid as one of the one of our protocols in serving in some emergency situations. So in terms of our service scope, we have been providing some psychological support service to reduce the emotional distress of the people who are affected by some disasters and emergencies. We have been using the protocol developed by the National Child Traumatic Stress Network and the National Center for PTSD because that is the protocol that is available in terms of the Chinese translation of PFA guide back in 10 years ago. And that's why we have been following the 8 core actions structure of the PFA training. And of course, we know that because the PS Center has been developing the new PFA training curriculum, so it could be something that we may change in the near future. And in terms of our training, we have been developing our volunteers using a standard 18-hour psychological first aid training curriculum. And after the 18-hour classroom role play and also didactic teaching, we have the examination that is also in place in order to assess the learning of our volunteers. So they would go through some written tests and also some role play exercise for the assessment. This psychological first aid service in times of disasters has been going on for the past few years, and we have been trying to collect some post-emergency data to show the some effectiveness of our services. So on the next slide, we have been trying to collect the data from the time frame back in 2013 all the way to this year. And some of the operations involved are some like urban disasters like fire, traffic accidents, and also some disasters happen overseas but affecting Hong Kong citizens. For example, in the high-end typhoon situation, we are also like supporting the Filipinos working in Hong Kong. So after all these emergency service, we ask our volunteers, the PFA providers, to fill in the post questionnaire in order to evaluate their own like self-efficacy, how confident they feel about delivering the psychological first aid. And the second part is their perceived effectiveness of PFA on the beneficiaries from the provider's perspective. So because one of the challenge in disaster research is to collect the feedback from the recipient ends, and this is also our case here in Hong Kong. So we have been trying to capture the experience from the provider's end. So on the next slide, we have developed some scales in order to measure these two aspects. For the first one, like the self-efficacy, so we developed some we developed an 8-item self-efficacy scale based on literature. Some sample items would be like, during the service, how confident are you in providing this core action? For example, referral to collaborative services. And then they will rate like on a 5-point Likert scale from 1 to 5. Not confident at all to very confident. And on perceived effectiveness, we ask the volunteers, like during the service, how effective do you think the provision of the core action, say for example, stabilization, in addressing the beneficiary needs? So they would also rate from 1 to 5, from not effective at all to 5 very effective. And on the next slide, we have been collecting data from the past several years. We have over 280 response so far. And from this graph, you can see that actually the self-efficacy of the providers, of the volunteers, are quite high. So they generally rate that they are quite confident in providing different core actions in psychological first aid during some post-emergency operation. And then on the next slide, we also show the perceived effectiveness. That is the effectiveness of that core action on the beneficiaries, as rated by the PFA providers. And from this and from the statistics here, we can also see that actually all core actions were effective from the perspective of the PFA providers in addressing the needs of those beneficiaries. And you can see the first 5 core actions. They are the contact and engagement, safety and comfort, stabilization, information gathering, and practical assistance are all rated very high in addressing the needs of the beneficiary. And also, so these are some of our statistics that we collect in the past few years. And on the next slide, we also want to show that because we also started to have one service that is the stationing service of our volunteers in the emergency room of hospitals. And this service, our objective is to reduce the psychological distress of the patients, vulnerable people, and also their carers who are affected by various like incidents that make them come to the public hospital emergency room, and then we provide a psychological first aid there, like during the waiting area. And on the next slide, there are some demographics of the people that we have served so far. We have served over 1,000 beneficiaries this year, and most of them are like Chinese, because the context is in Hong Kong, but we do have like other people, ethnic minority group here in Hong Kong. So we provide both the service to the patient and their family members. And on the next slide, it also echoed to our previous statistics, showing that the first 5 core actions are actually the one that is the most needed in terms of assisting patients and their family members in the hospital emergencies. And on the next slide, we also in this setting, because the patients and their family members relatively stay in the emergency room for quite some time, and that's why after providing the psychological first aid, we are able to collect some feedback directly from the recipients. So we give them like some like slip of paper, and then on that they are able to rate the satisfaction of our service and whether they feel better after talking to our team. So you can see over 90% of the service recipients think that they feel better after talking to us, and they are also satisfied with the service. I would say this is an attempt to collect feedback from the recipient ends, but of course, I mean, we are not able to ask very complicated questions in terms of like some basic principles of psychological first aid and whether they feel like how do they feel after talking to us, because it is in general a bit difficult because of the setup and also the context to ask about this kind of feedback. So the question would also be, is that a good reference to show the effectiveness of psychological first aid? And because of that, we also try to collect some information from our drill exercise. So on the next slide, we are trying to collect the results from our drill exercises. Because our psychological first aid volunteers, they act as like a beneficiaries and also the service providers in times of some drills, some scenarios. For example, the drill exercise that we work together with the airport authority every year, and then they also will role play some of the like the family members of the passengers. And after the drill exercise, we ask them, both those who act as the beneficiary and those who act as the service providers, how well the psychological first aid like give them. I mean, in terms of the hopeful principles, how well do they feel about the elements of PFA being implemented? And in terms of the beneficiary, how like do you feel you feel hope or you feel the safety after receiving the psychological first aid? So on this graph, we are able to ask them, because they are all trained volunteers, so they understand the hopeful principles, and we ask them about the 5 principles: the hope, safety, connection, calmness, and the efficacy. And they also rate on the Likert scale from 1 to 5. So we can see that actually there are quite positive evaluations of the psychological first aid provision from both ends. And from statistics, we know that there are no significant difference between the ratings of the providers and the service recipients. So it may be one of the I would say one of the ways for us to tackle the problem, the difficulties of collecting feedback directly from the recipient ends when the setup is not available. So maybe this also suggests to us from the perceived effectiveness from the service providers could also be one of the proxy when we are trying to collect the evidence for psychological first aid. And the next one, I would like to share a little bit of my own study. Because of my own PhD study, part of it is a cross-sectional study looking at the effectiveness of the psychological first aid training on the disaster responders. So we try to did one cross-sectional study after a maritime accident, after a vessel collision back in 2013. That was one of the really bad accident happened in Hong Kong that took 39 lives in that incident. And then we approached the responders who responded in this rescue. And then we tried to And then we try to have some like questionnaires for them. So on the next slide, we show that we actually distributed the survey, the questionnaire, to 110 disaster responders. And it so happened that 50 of them received psychological first aid training before, and most of them received one-day PFA training. And 58 of them, they received no PFA training before. And we tried to 2 months after the rescue, after the incident, we tried to collect some of the information about their own mental well-being and their own capacity to provide support to survivors and their family members. And we conducted some backward linear regression analysis to show the difference of the two groups. And on the next slide, from our analysis, we have found that the emergency responders who have received training in psychological first aid before the disaster happened, they report significantly, first of all, better knowledge about disaster mental health, because we also develop our own disaster mental health literacy scale. Some sample items would be asking them what are the 5 principles of providing psychological first aid after a critical incident, or what are the normal reactions after the critical incidents. So the group that have received training in psychological first aid report significantly better knowledge in that sense. This is quite like direct, logical, and they also demonstrated higher frequency of helping behavior during their support to the survivors. So we also have a report for them of providing psychological support to those people affected in that crisis, and they reported a higher incidents that they provide the support. And then we also found 2 months after the incident, those who have received PFA training before, they reported better psychological well-being, including their own coping, resilience, life satisfaction, and perceived social support from friends, after controlling some confounding factors like demographics and other factors during the operation. So we compare these two groups, those who have received pre-deployment psychological first aid training and those who do not. So we have found these differences. And on the next page, so we have seen that PFA training has been demonstrated one of the model that can enhance the participant their own self-efficacy on service delivery and also on the PFA knowledge. And this is one of the, I would say, effective ways of training in preparing for some psychological intervention after disasters. And from these series of data collection and also some results analysis, we also know that there are positive evaluations of the PFA proficiency from both the providers and also the recipient ends. We do not see significant difference from different angles, like the providers or the service recipients during the drill exercise in terms of achieving the 5 elements of the early psychological interventions, the hopeful principles. And it could also be one of the, I would say, potential way to evaluate the effectiveness and also the field applicability from the recipient's end. And then we also see that on the next slide, after some actual emergency operations, we have seen some high level of self-efficacy on PFA provision. And they also feel that all core actions of the psychological first aid were effective in addressing the needs of the beneficiary. And some beneficiaries, for example, in the emergency room example, they are satisfied and they also feel better after receiving the psychological first aid. And from the cross-sectional research that just I showed, there are some preliminary results showing the positive impact of the PFA trainings to the responders, their own psychological well-being. But of course, because the study is only cross-sectional, so no causal relationship is established in that sense. But it would also be one of the, I would say, like a positive results, preliminary results, highlighting the direction, some of the directions of our research. So lastly, on the implications part, I would say Hong Kong Red Cross has been doing the psychological first aid training in the past few years, and also had our own psychological first aid service in times of emergency. And these preliminary results also like showed us the effectiveness from the recipient ends. But of course, I mean, in the future studies, definitely we need more like evidence from the service recipients to show the real effectiveness of PFA, maybe in terms of the hopeful principles, or maybe in terms of their own psychological well-being, some of the outcome constructs. But it may also pose some challenges and ethical questions, like in disasters, because if we do RCT, like the randomized control trials, and we have to randomize two groups, and one to provide PFA and the other not to, then it may also pose some challenges, like some practical challenges in terms of the implementation and potential ethical questions. But I would say this could be one of the ways for us to look forward in terms of developing and accumulating the evidence for psychological first aid. So in terms of the presentation, Cicely, this is the part that I prepared so far.
Thank you very much, Eliza. I think it was very interesting to hear all the work you've done. I think because we know the challenges with conducting research on PFA, but I think in Hong Kong Red Cross, you've really tried to go about these challenges in different ways, and trying to find different ways to approach measuring the effectiveness of PFA. And I would like to now pass the word on to Koen van Praet from the Belgian Red Cross Flanders.
Okay. Thank you so much, Lisa, Cheung, for the great presentation. I think it's really interesting. I think mine will give some clearer view on what evidence can be. Okay, I seem to have control over the slides. You have asked me to cover three aspects: the current evidence for PFA, excuse me, yeah, the challenges of conducting research, partially covered already, and is it possible to conduct high quality research on PFA? How would it work? We come to the first question. It raises three other questions. What is evidence-based practice? What is PFA? And what is the aim of PFA? I'll show you a model from the Center for Evidence-Based Practice. I was doesn't matter. So for the Belgian Red Cross, we have a Center for Evidence-Based Practice within our organization that basically has the only or sole task to research if what we claim we are doing, is it evidence-based or not. And evidence-based practice builds upon three aspects. That is, first of all, the best available scientific evidence, the preferences and available resources of the target group, and then the practical experience and expertise of experts in the field. When we look, when we look, for example, at the TENS guidelines, I hope most of you are familiar with. The TENS guidelines have researched the available scientific evidence, and in the second aspect is that they had in a structured manner collected practical experience and expertise of experts in the field by a Delphi process. They were, the Center for Evidence-Based Practice has accepted this as an evidence-based practice because it was grounded as such. The problem is when you go and look at the TENS guidelines, is that it's pretty vague when it comes to practice. We see general components of the response. 2.1, the response should promote a sense of safety, self and community efficacy, connectedness, calm and hope. These elements of or components refer, of course, to the hopeful elements. So I hope everybody is aware of the hopeful elements. An extremely important article because for the first time, in my experience, there is consensus among very important experts. It sets the scene of psychological first aid. Very important. The baseline is do no harm. As long as you stay within this framework, we are not doing harm. But the challenges are to translate this to a certain situation, condition, and need. And actually, the authors challenge us to use these elements and to confront these elements with our psychosocial support activities. Excuse me. So what is PFA? When we look at the hopeful elements, and this PFA is any psychosocial intervention that aims to install these 5 elements. So PFA ranges from a set of good practices for lay people. For example, the WHO Look, Listen, Link approach, or the British Red Cross approach, which is called Calmer, Consider, Acknowledge, and just I don't remember. And we as a Belgian Red Cross, we have, I call it stock hopeful, we stay very close to the elements because we work in the immediate phase of the disaster. We are offering psychosocial support within hours and maximum a couple of days. But PFA is also covers multi-layer interventions, long mid-term, aiming to assure PFA elements on a larger scale. For example, confronted with a refugee center, the people running the center can use these elements to make sure they are met. They are talking about security, which is of course safety, but also cover hope by setting up education for the children, maybe involving people that from the center, parents or teachers, etc. Basically, all of this is PFA. When we look at PFA a little bit closer from another perspective, theoretical perspective, nobody can disagree. What do? We install a sense of safety. We avoid new triggers that activate the fear system. So when you're able to install safety, you make sure you don't make it worse. When you're able to install some feeling of calm, you lower the arousal. In doing so, you more mental resources become accessible. It's not only the stress. I mean, people can consider when they're calmer. They cannot when they're not calm. Promoting a self and community efficacy is about giving back control, and it's only possible when the above two are met. Connectedness, I don't go into detail, but very interesting that it connects to the neurological system, the panic system. And then we have installing hope. It's actually reinstalling a time perspective. Only possible if people are feeling safe and are calm enough. So that's the way how we use PFA in our organization, in immediate care, psychosocial support to people affected by critical incidents. The 10s were okay, but too vague, and we wanted to do a systematic literature search ourselves, and basically this is actually looking back at the best available scientific evidence. I'm not going too much into details. I recommend reading the article. But actually, we were looking at victims or people affected by disaster or traumatic events, and they should not be diagnosed or referred to by a health professional. I mean, first, psychological aid. The intervention could be anything. By lay people, first responders, etc. And we were very open to all measuring parameters: resilience, empowerment, stress, coping, etc. But, and this is very important to our Center for Evidence-Based Practice, the studies should be have a control group. They should be controlled, experimental, or less favorable observational study design in order to be included. In short, we were included about 11,000 articles, and we have none of the articles were included. Why? We see three main reasons. First, there is not a lot of interesting evidence in general in pre-hospital care. Secondly, it's mentioned by the previous speaker, it's difficult to perform when you want to research on the people affected themselves. And the third reason is that PFA is a multifactorial intervention. It was very difficult. Basically, you have all kinds of interventions that are within the framework of PFA, but often not well defined interventions. So what are the challenges? It's very strange to speak to an audience that doesn't respond. Challenges of conducting PFA. So I hope all you all with me. But before, we cannot say that PFA is successful. We can say that a certain approach or a certain way of working is, we can find evidence. For example, the WHO look, listen, link adaptation. There should be consensus on the baseline and what is offering safety, what is installing calm, etc. And very important, there should be consensus on the outcome. I was very much intrigued by the previous speaker's presentation, because I think this is a better example, or very good example of what we want to do. A lot of the research we found was actually looking at post-traumatic stress syndrome symptoms and using checklists. But if you want to lower the emotional distress, you don't measure some outcome that is actually weeks away from your intervention. You just want to know if you were able to offer or to lower the emotional distress. And the second step could be that if you can lower the emotional distress in the first hours before the people leave the scene, for example, if that has an impact on the longer term. That's a second area of research. We use as a standard the PICO, in which when we want to judge if a setup was okay, we we must find answers to the next items. PICO, population, intervention, control, and outcome. Comparison. Okay, it's not control. Population. Often we found affected by critical incident, affected by disaster. So population is often very difficult to it was too broad to think affected by disaster. We're talking about the person who was next to the bomb and the person that had to be evacuated that was living 5 blocks away, for example. The challenges is to have a well-defined PFA-approved intervention. So is this intervention within the framework of PFA? And then you have the comparison group, not the control, excuse me for this. Depends on what you want to learn from your research. PFA, no PFA, trained versus lay people, etc., etc. And the difficulty was the outcome, but I think Eliza has covered that well with the skills she was using. It's much more interesting to use this kind of skills than to use this symptom checklists. And then you asked me a very difficult question. Is it possible to conduct high quality research? Yes, of course, it's possible to conduct high quality research. But having said this, is that within the Red Cross we have the journal club. We come monthly together and discuss articles. And very often we have the problem that the findings of the authors are not statistically significant because the group is too small. Okay. And somebody said the other day, we cannot include 6 billion people in our research. So this made me think, because we are working in an area where not a lot of money is going around, compared to, for example, pharmacology, where we have big firms, a lot of resources. If something is significant, it means that somebody makes money with it. This is not the case in our very specific area. But anyway, when we give it a try, population, when we do another PICO, could be evacuees in a reception center. The intervention well defined. The control could, the comparison could be a control group that has another approach, maybe is offered a not PFA, but social assistance by untrained people, for example. And the outcome should be short-term perceived emotional distress. For example, mid-term could be sleeping problems, but this is just an idea of how it could look like. I think the ethical issue is covered here because when we have reception centers, we have different reception centers. We are not in control of who the people are that run the reception centers. So anyway, one time it will be local volunteers doing their best and working on a human level. Another reception center has trained PFA volunteers. So this might be a possible setup for high quality research. Having said this, it's difficult to say the causal. It's difficult to define the causal relationship, but I think we need to do what actually Eliza is doing with the Hong Kong Red Cross. It's to collect data and to set up designs that are much closer to what we are actually doing. The last slide is references of articles I mentioned during my talk. Thank you so much.
Thank you very much, Koen. I think that was very interesting, highlighting some of the challenges, and I also think the PICO framework can be quite good in thinking about the things that we need to define to have a proper research on PFA. Lastly, I would like to give the word to Ferdinand, our moderator for our Q&A session.
I'm Ferdinand Garoff. I work for I'm sort of have previously been affiliated with the Psychosocial Center in Copenhagen, and I'm still part of the roster group, as well as being part of the Finnish Red Cross responses nationally and internationally. And as mentioned, I currently work at the University of Tampere with a study where we investigate the rehabilitation model for unaccompanied minors. Now, basically, my first question was something I sort of had in mind based on the article that you mentioned, Koen, about the methodology, or sort of how do we define psychological first aid? And I think it was quite clearly defined in the approach used by the Hong Kong Red Cross. That was my impression, at least, with the various core actions and the training program and things like this. However, sort of comparing with sort of what was covered in the systematic literature review conducted in Belgium, it seemed more like we're talking about an approach based on the Hobsbawm principles, for example. And I think you covered some of these points in your presentation already, Koen. But would you, Eliza, for example, would you like to say a few words about this? Should we approach sort of psychological first aid as a methodology, as in a set of core actions that are included, or is it more something which we should view as an approach which is based on certain principles, which we then apply in different manners, in different settings? What is your point of view? If I'll pass the word first to Eliza, and then if you have some comments, Koen, as well.
Yes, Ferdinand, thank you for your question. I think it's a challenging one. I would say like psychological first aid can be viewed as a set of techniques for people to implement immediate psychological support to people affected by disasters or critical incidents. But of course, it still has its own like flexibility that maybe some people may also view it as an approach. Like we can provide psychological first aid on individual basis, on group, or sometimes from our experience, we also provide psychological first aid through the hotline, like through telephone. We can still make sure the person feels safe and also have the practical assistance that we can provide to them. So maybe it's in terms of how you look at it. And also when we do like research, it would always be good if we have more concrete, like a construct of PFA, like different dimension of PFA, and this may also reflect the reasons why different organizations are having different models of PFA based on the 5 like a hopeful principles. We have the triple L's from the WHO. We have this NCTSN like 8 core actions, and we have heard about the calmer and also a couple more. They are available out there. No matter how you try to like classify or to group them under different constructs, we still base on the same 5 like principles. So I don't know if I really answer your questions, because this is really like an advanced one, I would say. But in terms of research, definitely the construct and also different facets of the PFA would be helpful, because we want to make it more measurable, and then we can demonstrate the impact on the people.
Okay, thank you very much, Eliza. How about you, Koen? Do you have any points of view or anything you would like to add to this question?
As I said, we use kind of stock hopeful method, because for us it's the basis. The PFA elements must be there, and then it depends on people affected, the needs, the assessment, and the person who delivers it, in what kind of dimension we're working. And for example, the most simple way would be a list of good practices. Make sure people are safe, let people talk if they want, connect people with family members, you know, 5 items that can be carried out by anybody that has this leaflet saying what you have to do. This is PFA. More advanced PFA uses the interaction, and for example, through the phone, you talk to somebody, you listen, and you assess if somebody is rather angry because he can't do anything. So then you go to the self-efficacy and trying to get control back. Or somebody is scared, and then you have to focus on the safety. Or somebody is missing a person, and you focus on connectedness. So this is also PFA, and it can be on a larger scale. So I don't think we will find ever PFA as being evidence-based, but we will find, I think we can set up research that PFA compatible interventions don't do harm first, and PFA interventions have actually an effect. Am I answering your question?
I think very much so. And that kind of leads into the following question, if I can continue a little bit with you as well. The second question, as you all can see, is that should we continue delivering the psychological first aid in the light of this limited evidence? And what would need to be adjusted on that point? And I think sort of, you mentioned already one of the points I would have liked to raise, the question of doing harm. One reflection sort of on this point on my behalf is that, of course, the Hobfold principles are not how should I say, my understanding is that the Delphi study, which was done to sort of bring these about, is sort of, they are based on certain researched principles, but it's not, how should I say, each of them has not been researched separately as part of an emergency response intervention. So would you like to address a little bit this point, sort of, on the one hand, sort of, what can we safely do, and how could we sort of affirm that psychological first aid is something which is useful and sort of apart from just a reference to the Hobfold principles?
Can you repeat the last sentence?
I'm just thinking in terms of, there's a lot of references to the Hobfold principles, but the sort of the general, but sort of my understanding of that sort of study is that it's sort of based on research principles, but it's sort of, but each of them is not necessarily based on evidence from an emergency setting. So what kind of, what would we need to look at in psychological first aid to sort of have independent evidence of the efficacy of that? And is there something we can already do at this stage to minimize doing harm?
First of all, should we continuing delivering PFA? Yes, because I think it's the first time that so many experts agree on what is necessary not to do harm. We must not forget that there was 20 years ago, a big focus on preventing PTSD, and one was using the knowledge of working with people suffering from PTSD, and when one brought this to the first hours, the first days of the intervention, we were using techniques that were dangerous. For example, you must talk about it. No, this is not safe to force somebody. There were several things going really wrong. For example, trying to identify individuals at risk and separating them from the community. This is doing harm. I've seen myself in Croatia, a refugee center, and next to it there was a refugee center for the raped women, and everybody knew from the big center what happened to the ones in the smaller center. This is not possible when you look at the PFA principles. So yes, It's a very good framework, not doing harm. When we look at each element separately, which we try to do, it's very difficult because you very easily come to common sense issues. Of course, offering safety is not the same as the sense of safety is not there by offering safety. So for us, it was a good exercise to teach our people to stress the fact that someone is safe in a reception center. If you're in a reception center, this is here you are safe. It's more effective than just putting people in a reception center. There is little research on that, but it comes very close to common sense when it's, of course you have to offer safety. Of course you have to calm down people in order to make them able to see what is a priority for them. Is it the priority to inform their relatives at home that they're safe? Yes, it's a priority. They don't see it when they are too much distressed. They do other things. They keep helping others or etc. So I found it very difficult trying to find answers for the separate elements. Excuse me, I find it very difficult to find contra-indication. So yes, there is no research in this disaster settings, but basically we're talking about distressed living creature. You can almost go back to the animal part of the brain and to very basic hardwired reactions. There is the fear reaction, there is the anger reaction, there is the panic reaction. And PFA actually covers or gives an answer to softening the impact of this reaction. Doing so, people have the ability to access the other parts of the brain where they can reflect, where they can think about priorities, where they think about, again, in time sequence. I must be careful not to go way too far off the question, but this is basically what I have to say about it.
Okay, thank you very much, Koen. Eliza, would you like to add something on this point?
Yes, I think this is a really good question because for now, I mean, psychological first aid seems to be our gold standard because it's developed from Hoffel's principles and from research. We know that the 5 principles are really helping people to recover from the crisis. So I mean, in principle, it should be helping people. But the challenge that I would say, the real challenge lies in the implementation of the psychological first aid. Because these are the principles, but in real life practical scenario, how do we really actualize those calmness and safety? And I particularly like the idea, Koen, you just mentioned, the physical, the safety that we provide doesn't mean that it echoes directly to the sense of safety of people. And that's why it's so important always to engage the community to ask how they feel about several things. So in some of our research, we always have the question asking, no matter it's the providers or the observers, do you see any potential harm during the implementation of PFA? Because that would also be one of the ways for us to monitor the quality of the service to make sure that we are really doing no harm. And by engaging the community, by asking for feedback, it is also one of the ways for us to accumulate the practice-based evidence that is so important in the humanitarian field. So in my opinion, I would say on the theory, we don't see any problems of PFA, but for the implementation, we should really be mindful that the do no harm principle is there to guide us, and also we have some ways to make sure that this is really upheld.
Thank you very much, Eliza. Would you have anything else to add on the question of evidence-based practice in general, as to the last question for our question Q&A?
Yep.
And would you have any recommendations or suggestions on that point?
Right. Of course, I mean, in humanitarian contexts, it's sometimes difficult to design really perfect study because of the challenges and also some ethical reasons. But sometimes I would say follow up on the beneficiaries to show some more long-term impact of receiving PFA may probably be one of the directions that we can go for. And of course, we may have some control to compare, but this is really up to whether the context allow us to do so. So that may be some of the like practical challenges in order to accumulate this kind of like evidence. But I would say by collecting the evidence and by collecting like information about the PFA implementation itself is already beneficial when we are providing the humanitarian assistance to people.
Thank you very much. I think one thing which I very much appreciated in the studies you presented previously was sort of the various sources of data where you collected data from, not only from the beneficiaries, which would of course be sort of, or recipients, which would of course be sort of key, but also from providers and so on. And that could sort of provide sort of a opportunity to triangulate the data collection in a way to sort of make a comprehensive and sort of maybe identify factors which are unexpected in your implementation of the model. So I very much appreciated that. Any last points from you?
Okay, short point. I think we should look at more experimental settings and look at in how far they can be used or implemented in our approach. And one example is the peak end rule, which is Kahneman's concept, which says that how you look back at an event, how you emotionally remember an event, has to do with the peak of the emotions, how bad was it, and the end of the event. For example, leaving the emergency room and going back home. It seems that there is a conclusion at the mental level, and it's important at the end, and the most distressing event, they kind of flatten each other. This is documented, there is interesting studies, and it's used in a commercial way. For example, when you go shopping, it can be, it's very important that at the end, the person at the counter is friendly to you. And then you remember the shopping activity as more positive. And Kahneman actually mentioned this in an article in which he says emergency personnel should be aware about this rule. And I think it's interesting to look broader and not in more experimental settings what is available there. Thank you.
Okay, thank you very much on my behalf as well. I'll pass you to Cecilia now.
Thank you very much, Ferdinand, for presenting these very interesting and difficult questions. And this leads us to the end of this webinar on PFA between evidence and practice. I think we've covered a lot of topics from the sort of more abstract things. How do we measure it? How do we do the proper setup? What's actually the outcome? What is PFA? Is it a technique or an approach? But also I think we've seen some very concrete examples of how we can try and come about it and how we can actually try and measure, even in an emergency room setting, to measure how the recipients feel about the PFA services they receive, and also how we can look at the responders and see PFA as also something that benefits their mental health and well-being in disasters. So I would like to thank all of you for calling in from, I think we cover all of the world, from the Philippines to Australia to various places in Europe and probably places I don't know. So thank you very much for that. It's been very interesting. As I mentioned in the beginning, the webinar is organized by the Red Cross Red Crescent Research Network on Mental Health and Psychosocial Support.